Thank you very much. I'm honored to be here and really delighted to have another visit to your great country. So I've been asked to talk about dual antiplatelet therapy after ACS. Now, you know both from your own registry data and from the registry data like this GRACE program that there is a considerable 5-year death rate after ACS. But I'm pointing out here these are STEMIs, non-STEMIs, and the unstable anginas needed an independent, separate measure to demonstrate that they had coronary disease. Because my worry is many of the unstable anginas today with the higher sensitivity troponins are actually quite heterogeneous. So we're going to start with the first question. Your patient says to you, your patient with non-STEMI says to you, "Doctor, thank you very much for looking after me. How much of my risk is ahead of me over the next 5 years compared to the risk that I've just had when I presented?" So let's ask the question this way. If the patient said, of all the risk from time 0 with my non-STEMI to 5 years, how much of it is after hospital discharge? Is it, we'll ask you to vote. Okay? How many say 50%? You have to vote at least once. 40%? 30%? 60%? A few votes. 70%? 80%? 90%? We have a lot of abstainers. If we're in Australia, everybody has to vote. Well, the truth is that 85% of that risk is actually, a risk for death over 5 years is ahead of the patient. And only 15% it was during the hospital phase. So it's worth us remembering that we, despite current standard of secondary prevention, have not fixed everything by the time they leave hospital. And secondly, we've done an analysis to ask the question, not just what are the first events, but for our patients, what they're concerned about is all the events. So here I'm showing you the myocardial infarctions, people who have one or more myocardial infarction, one or more revascularization, one or more stroke. And look at this, half of them have an ACS rehospitalization within 5 years. And we track this in Belgium, we track this in the UK, identical data. So the message is the long-term outcome has considerable event rates, and a number of these are recurrent. Now, very interestingly, in the PROSPECT study conducted by Greg Stone and colleagues in the US, they undertook intravascular ultrasound to examine the lesions over the course of time. And the important message from their study was that about half of the events were culprit lesion related and about half were non-culprit lesion related. So this means that even if we've dealt with the index lesion that was responsible for the ACS, half of the events are going to come from other lesions. So we need to deal with the underlying disease process. I'm going to tell you a little bit about an interesting large-scale observational program with more than 150,000 patients. There are several countries participating, the US, the UK, Sweden, and France, and these are programs, this is observational data with follow-up and careful characterization of the endpoints. Now, some people say to me that, well, you did the GRACE program and you looked very carefully, but actually things are not that bad now. Well, the answer is they are. Because have a look at this. This is from 97,250 individuals across all of these countries. And 18.3% suffered an MI, stroke, or death from the time of discharge until 1 year. So if we think the problem's solved, it isn't. And so that's within 365 days. Now what about this? This is also very interesting. If you're reviewing the patient a year after their ACS and you tell them, well, you've done very well in this year, actually 1 in 5 patients who are event-free in the first year are going to have a stroke, cardiovascular death, or MI in the next 3 years. So even a year after their event, they're not free of the risk. What about the influence of diabetes? And we know in some parts of your country, as it is in ours, diabetes is quite a problem. So if you have diabetic patients, the risk is higher. 1 in 4 patients with diabetes who are event-free in the first year have an MI, stroke, or death in 3 years. And you can see it's much higher for diabetics versus non-diabetics. Similarly, if this patient has had an MI in the past, then the risks of them having a further event are increased. So patients with a prior MI versus those without a prior MI. And here you can see chronic renal disease. I think this is a wake-up call for us because the impact of chronic renal disease has often been underestimated. We know it's bad, but we don't realize that it contributes to the risks of MI, death, and reinfarction. So if you have chronic renal disease, the risks are higher. And some people say to me, well, those are in registries. But what about if you took a really well-treated population, as well-treated as you possibly can? And I'm sure many of you, as I do, have collaborators in the TIMI group. And I was not involved in this study, the solid TIMI 52. This study was looking at daraplidib as a way of modifying the plaques and lipid. And actually, the study drug failed because it was no different from placebo. But this study is useful because it says to us, in the modern era, published in 2014, in a selected population with some high-risk people excluded, well treated in secondary prevention, 15% cardiovascular death, MI, and stroke in 3 years. So if anybody argues with you, just giving them a current secondary prevention will fix this, it isn't. Now, does it matter in terms of the future events when you had your index event? So this looks a little bit complicated, but it says in the dark gray, if your previous ischemic event is within 1 year before baseline, these are the dark colors. In the slightly lighter gray, it's more than a year. So in other words, the darker gray is slightly worse in each case. But more than a year, there's still an important event rate. So this is saying that this patient has told you and I that they've got underlying vascular coronary disease and they're going to have future events. Now, I was involved with Deepak Bhatt in running the Charisma trial. And in the Charisma trial, we asked a straightforward question. Would the combination of aspirin and clopidogrel be better than placebo? And it was placebo plus aspirin. And the answer was there was a strong trend for the whole population, but it was not significant. But this population included people with previous coronary artery disease and people with various prevention states. And by design, we looked at the individuals with prior MI. So this reinforces exactly what we've been talking about. If you've had a prior MI, the treatment with clopidogrel and aspirin, and clopidogrel is clearly one of the older-fashioned phenopyridines, still had about a 23% risk reduction. So that's quite striking. Oops. It is at the cost of some bleeding risk. No evidence of an excess of severe bleeding, gusto-severe, or fatal, or primary intracranial hemorrhage, but there was an excess of moderate gusto bleeding, 2% versus 1.3%. Now, you also will have heard about the DAPT study. And the DAPT study is asking the question about dual antiplatelet therapy beyond 12 months. And we know that that study as a whole reduced ischemic complications after coronary stenting compared to aspirin alone, but there was some increase in bleeding. So I want us to look at the DAPT study in a bit more detail. What you can see is that in the study as a whole, there was a reduction in stent thrombosis, a reduction in death, MI, or stroke as a composite, and in myocardial infarction, about a 2% reduction. But the human cost of this was a 1% excess in moderate or severe bleeding and a 0.5% excess in deaths. Some of those deaths were actually probably incidental malignancies, but nevertheless, this is what it showed. So at the end of that, my colleagues said, well, how do we balance these? You know, is it in favor of reducing the blue events, or is it the ones on the right that we've got to be worried about? In the meantime, the study that was undertaken was Pegasus, and Pegasus was with ticagrelor, and these were individuals who'd already completed 1 year after their ACS or their stent. They had their MI 1 to 3 years previously. And they tested 90 milligrams of ticagrelor or 60 milligrams of ticagrelor versus placebo in the period from 1 year onwards. And in absolute risk reduction terms, it was about 1.2%. And you can see it's very similar for the 2 doses of ticagrelor. And if you lined up the components of the endpoint, cardiovascular death, MI, or stroke, cardiovascular death, MI, and stroke, they were relatively similar and encouraging trends in favor of the combination of using ticagrelor in that setting. But in terms of bleeding, what you can see is there is an excess of bleeding. And in red is ticagrelor 90 milligrams, and it's higher than the blue 60 milligrams, and it's higher than placebo. That's major bleeding, minor bleeding, fatal bleeding was no excess, intracranial hemorrhage was no excess. So what we can conclude from Pegasus is adding ticagrelor to low-dose aspirin in stable patients with prior MI, the absolute risk reduction is about 1.2%. And you have to decide if that is an appropriate gain for that treatment. Because ticagrelor increased the risk of major bleeding, but not fatal or intracranial hemorrhage. And so you gained 1.2% in cardiovascular death, MI, and stroke, and your hazard was 1.1% for 60 milligrams, 1.5% for 90 milligrams in TIMI major bleeding. So how can we work out who might benefit most and who may be most at risk? Well, the DAPT investigators have done a very interesting analysis that was presented quite recently at the American Heart Association. And they looked at the combination of risk of ischemic events and the risk of bleeding events. And they said, instead of just measuring these separately, let's look at these together. And so they looked at the combined treatment effect with ethenoperidine. And this is mostly clopidogrel. Some of it was prasugrel, but mostly clopidogrel. And the way they did their score is if you've got a low DAPT score, it means that you've got a greater increase in bleeding and a smaller reduction in ischemia. Higher score is higher potential benefit. So it's a greater reduction in ischemia, a small increase in bleeding. So that's the way their score worked. And they did a Kaplan-Meier analysis. And so what you can see is that their risk model actually worked. So this is stent thrombosis, and the highest quartile of their population had most benefit. And you can see for myocardial infarction, the highest quartile, the most benefit, but the lowest quartile had the most risk of bleeding. And mortality is the most in the lowest quartile there from the intervention. So the interesting approach is to say, can we reduce the number of net adverse events using a score like the DAPT score? So if the score is 2 or more, there may be greater potential for benefit. If it's below 2, potential for harm. And so this is tested in the entire population. And what it shows is that for stent thrombosis or MI, there is a trend in this DAPT group who are the score less than 2, a trend but not significant. MACE, a trend but not significant. Gusto, moderate severe bleeding, worse. Worse. Now what about the high DAPT score? And this is 2 or more. And the answer is it worked. The separation of the curves was substantial in favor of the continued thienopyridine, whereas gusto, moderate and severe bleeding was not increased because these were low risk of bleeding. And so we can see that for a DAPT score of less than 2, this is the risk difference, which is modest. Above 2, the risk difference is much bigger. And the number needed to treat, if you've got a high DAPT score, is only 34, whereas it's 153 with a low DAPT score. And moderate to severe bleeding, you can see here, with a high DAPT score, it's 272, a number needed to harm from bleeding, whereas it's only 64 for the low DAPT score. And the net adverse events is obviously much better for the low DAPT score. For the high DAPT score. And so if you select your patients on the basis of a high ischemic risk, low bleeding risk, you only need to treat 37 to have a benefit. And this is the excluding the paclitaxel eluting stents, and essentially it's the same result. So the summary is that the score identifies patients with the greatest anticipated benefit versus harm for continuing dual antiplatelet therapy beyond 12 months. And so my concluding slide before we start our discussion is that after ACS, the risks certainly continue. And that's not just from the older studies, that's from large current observational registries and large trials. About 20% cardiovascular death, MI or stroke in the first year, and 20% further in the next 3 years, and higher risks in those with prior MI, diabetes, or renal dysfunction. And the risk is consistent across the different healthcare systems. So it's not as though one is lagging behind the other. Patients at higher ischemic risk and lower bleeding risk potentially benefit from more prolonged dual antiplatelet therapy. Thank you very much.